This conference
because
will
this is
now be
like
recorded.
Yeah, the perinatal mental health now having a lot of attention from the college, the RCOG, and the government. Actually, they have put like 2.5 billion um, English pound for the development of the mental health care, okay, and to build up a special unit for those pregnant with problem in the mental health. And nowadays, because of the current situation, okay, I think the rate of the complication from the antenatal and postnatal problems will increase, supposed to be increased. And if I ask you a direct question about the maternal death, okay, what is the most common cause, indirect cause of maternal death?
indirect is cardiac cause.
Okay, so if I modify my question and I said it, the most common indirect cause during the first year after giving birth.
That is suicide.
Yes, excellent. Thank you very much, doctor. So, because suicide now counts as the major cause of postnatal postpartum death, okay, that's why it's very important, and there is a nice guideline focusing on the prenatal mental health. And by the way, this nice guideline updated recently, okay, and this update recently regarding some safety of the drug Valproate. Okay, there is three forms of the drug Valproate, okay, and all of them are transformed in the body or metabolized into valproic acid, which have a lot of problem for the fetus and neonate afterward. So they now started to put some new advices for the valproate use, not only in pregnant women, but even in girls who are in the childbearing period. Okay, so if you are having a girl with like teenager, okay, all practitioners should know, okay, that valproate should not be given unless it is the last option. It's the only effective drug, and as well, this girl should have contraception, a reliable form of contraception in place. Okay, so it is not recommended at all, even to use in non-pregnant women. And the only way to use it is with reliable form of contraception and with cooperation between the practitioner psychologist, GB, and all the doctor. If the lady or the girl is planning to get pregnant, they should have counsel her about the risk and the potential risk to the fetus, malformation, and the harm that valproic acid can cause, and to assess her case if this is the only choice for her or there is another safe alternative. If there is any another safe alternative, the valproic acid should stop gradually. Okay, so this is the main advice for the MRCOG, okay, that's been released recently, and there is a patient card just for the public health and the public to get this information, and there is a booklet as well. So please take care if you are planning for part 2 or part 3. The safety issue now is very important, okay, because usually the exam will focus on what is going on in real life. So if there is a safety issue across the UK and there is a new update of the NICE guideline due to the safety and there is an alarm from the MRCOG, please take care of this. Okay, read it carefully and you should know what is the new recommendation. Okay, this is what I want to focus on before starting talking about the prenatal mental health and what is the effect of the psychological disease or disorders on a pregnant woman And how would you screen for that in the very beginning of the antenatal period, even starting from the preconception? Okay, how would you give a woman advice who is suffering from a psychological disorder, and how will you arrange her pregnancy? How will you give her a counsel regarding the pregnancy and the safety of the drug? Okay, there are some form of drug, certain manifestation or side effects that you have to be aware of them. It's very important in your exams to ask about the side effect of the drugs, including sodium valproate, lithium, SSRIs, carbamazepine. So every drug that's used in the psychiatry or the psychology treatment should be known for its side effects. Okay, and you have to counsel your patient about this and the drug choice and the planning for pregnancy and the involvement of her special team and the mental health team or mental health service, okay, is very important. So let's start. There is a lot of terms that I don't know if you are familiar with them or not, okay, but I will tell you what is normally happen or routinely happen when you have a woman in the very early stage of pregnancy. In the booking state, you have to ask her about her mental health. While you're obtaining your obstetric history, you have to ask her about the mental health history, okay? And how would you ask her? This is very important for you to know what about the questions or what are the questionnaires that have been used to check or to screen those patients who are at risk of psychological problems during pregnancy. Okay, so you will start by two questions. They are called the holy questions. The holy questions, it is a form of screening for depression disorder. Okay, so you will ask the woman first question: during the past months, have you often been bothered by feeling down, depressed, or hopeless? Second question, you will ask her about during the past months, have you often been bothered by having little interest or pleasure in doing things? Okay, so you have to write down the answer. And if there is anything that you want to help with, okay, so you help the woman in a non-judgmental way to express her feeling to you. Okay, so if you see any positive answers from those holy questions, okay, you have to move next level. Next level of questionnaire, next level of screening for depression disorder, it's about the patient health questionnaire. Okay, the patient health questionnaire 9 is a form of questionnaire. You will give it, it's actually will be filled by the woman herself. Okay, you will give her this question and she will write down her answers, and with a certain score you can detect if this woman has depression, okay, mild or moderate or severe depression. Okay, so it's very important to know the names of those questionnaires, okay, and to know the level of or the stepwise of screening. So you will start by screening by the holy questions, screening for depression. And there is another thing you will do for screening for anxiety disorder. Okay, anxiety disorder like eating disorder, like OCD, like post-traumatic stress disorder. Those disorders, okay, have also a specific tool of screening that is called GAP2. Okay, so the GAP2 is your form to ask your screening tool for anxiety disorders. Okay, so generalized anxiety disorder scale called GAP2. What is the form of this question? You will ask her, over the last 2 weeks, how often have you been bothered by the following problems? First is feeling nervous, anxious, or on the edge. Second is not being able to stop or control worrying. Very important that you have to keep those questions, the holy questions and the God-to questions for part 3, okay, for the obstetric history. It's very important, okay. For you, in the level of part 2, you have to understand the function of those screening tools. Each screening tool, we use it in which situation, okay? So you will ask the woman about the holy question to screen for depression, and you will ask the woman about an anxiety disorder by the GAD-2 scale, okay? You will ask her as well of history of severe mental illness. History of severe mental illness means like episodes of panic attacks, psychosis, admission to a psychiatric unit, personal or first-degree family history. Why it's very important to ask about the family history? Because it's a major risk factor in developing postnatal depression and postnatal psychosis. Okay, so very important to ask about the personal and family history, especially first-degree family history. You will ask as well about alcohol or drug misuse. So those answers, those questions you have to ask in the booking visit to every pregnant woman, so you will have an idea about her mental health or her background if she's complaining of any psychiatric or psychological disorder. Okay, so this is the introduction to the perinatal mental health and the names of questionnaires. I just want you to know the names. The GAP2 questionnaire are screening tool for an anxiety disorder. The holy questions are the screening tool for depression disorder. So what if a woman answered positive for the holy questions? So you will make another means long questionnaire. She will fill it by herself, called the Patient Health Questionnaire or the PHQ-9. Okay? If the woman, this is for the antenatal. If we are talking here about a postnatal visit, there is another form of questionnaire that is called Edinburgh Postnatal Depression Scale. Okay, so you have those questionnaires if you feel the woman is depressive or a low mood or she's suffering a depressive disorder. If you have any clinical suspicion, you will give her those questionnaires, she will fill herself. Okay, there is course score for those scales, and according to the scores, it will be divided into mild, moderate, or severe. Okay. For the anxiety disorder, if you feel the woman is irritable, she is having problems sleeping, she has some obsessive disorder or some post-traumatic stress disorder, some eating disorders like bulimia or anorexia nervosa. So you have to go for the next level because there is a specialized service for the anxiety disorder. Okay, and the next level will be the GAP-7 questionnaire for anxiety. Okay, so to summarize again, the names of questionnaire, sorry, I have to repeat it because I want to make sure that you understand the stepwise approach. Okay, for screening for depression, I will start with the holy questions. If the woman answered positive, means that she is depressive or you have any clinical suspicion, you go for the Patient Health Questionnaire or the Edinburgh Postnatal Depression Scale. This is according to the gestational age. If she has delivered already, okay, so it's the Edinburgh Postnatal Depression Scale. If the woman is in antenatal clinic, so it will be the Patient Health Questionnaire or the PHQ-9 form, okay, for a full assessment. Asking about anxiety, you will start screening by the GAT2 questions. GAT2 questions It is the first scale to ask or screening for an anxiety disorder if the woman also a positive score of 3, so you will have to go to another step, which is the GAD 7. Okay, so by knowing those questionnaire names, now I will be happy to move to the next of our lecture today. Any question here?
Dr. Abba, actually I joined late. When we will use the GET 2 questionnaire and when we will use the GET 7, can you clarify that?
So Dr. Sumar, please can you repeat your question again?
Actually, I joined just now. That's why I'm asking that GET 2, when we will use GET 2 and when we will use GET 7.
Okay, you will use the GAP 2 as a screening. So the first step when you want to screen a woman in the antenatal or in the postnatal visit, you will ask her by the GAP 2. Okay, it's 2. So you will start by the 2. Okay, if the woman have already a problem, an anxiety problem, or answered any positively, positive answers means that she is yes, suffering from a problem or an anxiety. So go for the next one, and next step will be GAT 7. So I will start with the 2, then I will go for the 7.
Okay, thank you.
I would like to ask you again, because some of your colleagues say that the voice is not clear. Is it the same for everyone?
For me, it's clear, ma'am.
Okay, so
For me also, it's clear.
okay. Okay, so Dr. Ali is clear, Dr. Nada is clear. So please, Dr. Rasha, if you can log out and log in again to the meeting, I think the problem of voice will be corrected. Okay, this is to have an idea about the scoring system in the patient. Okay, I don't think it's very important to your exams, but to have an idea, this will have a score from 0 to 27. Okay, so from 0 to 4 means that none, 5 to 9 means mild, 10 to 14 means moderate disorder, 15 to 19 means moderately severe, 20 to 27 means severe. Okay, so, and this is about the generalized anxiety disorder scale, the GAP 7. This is what you need to know about this scale or about this questionnaire, that this is the next step or the second step when you are assessing a woman for an anxiety disorder. If you suspect that your lady is alcoholic, okay, or there is alcohol misuse, so what you need to do is you have to refer her to the proper service, and there is also identification tool called ODET. Okay, it's abbreviation for Alcohol Use Disorder Identification Test. Okay, you just need to know the name. This is for the alcohol misuse. If you think that the woman have a substance misuse, means that she is taking any form of drug, recreative drugs, or like heroin, codeine, marijuana, or anything of this. Okay, so you will have to use another form which is you have to follow some recommendation and identification assessment. Okay, there is a special guideline for the drug misuse and psychological intervention. It's not required from you, but you have to know that there is a special service for the drug misuse, and there is also some questions in your curriculum asking about some substance misuse and its effect on the pregnancy and effect on the fetus. As I can remember about codeine, amphetamine, okay, it's associated with
FGF.
okay, so it will be associated with preeclampsia, IUGR, okay, placental abruption, and sometimes fetal death. So you have to know all of this. And if I ask you about cannabis, okay, or marijuana, is it associated with any form of malformation, fetal malformation?
No.
No, yeah, excellent. So it's not associated. Yes, it's not advised for a pregnant woman the form of smoking, but there is no evidence that cannabis or marijuana cause any fetal malformation during development, okay? As a guideline, the NICE guideline focus on some disorders. I just gave you some idea about it. There is some common disorders that pregnant women may have. It's like form of maternal medicine. It's like if you have a cardiac patient or have a renal patient, you will have also a psychiatric patient who may have some form of psychiatric disorder like anxiety, okay, like OCDs, or maybe have psychotic disorder, which is more severe, like schizophrenia or bipolar. Okay, so you have to know about every one of them. You have to know about the disorders. Anxiety, non-psychotic disorders means not associated with hallucination or psychosis, like anxiety disorder. During the prenatal period, it can include generalized anxiety disorder, OCD, post-traumatic stress syndrome, and phobias, including tocophobia, which is very important to know how to manage it. Okay, tocophobia means fear of birth or feeling of vaginal birth. A lot of women have experience of tocophobia, maybe primary or secondary. Primary photophobia can be associated with a bad experience in childhood, like sexual assault, or because she heard from someone of her friends, her sister, about some traumatic birth, so they develop primary tocophobia. Secondary tocophobia means that the woman will develop fear of birth after a traumatic birth experience, okay, like operative vaginal delivery or fourth degree tear, something like that, okay, or prolonged labor ended by emergency cesarean and complication. So they may have a fear of giving birth. This is called tocophobia, and we have to know how to deal with it. Anxiety disorders are categorized using the number of symptoms experienced and the level of impairment. Anxiety disorders are highly comorbid with depression. So most of the patients who have anxiety already have depression as well. Mild anxiety should be treated with facilitated self-help, okay? So they can guide you, your GP, your midwife, they can guide you for some techniques how to overcome this mild anxiety. But moderate to severe episodes can be treated with high intensity psychological intervention. It's like form of repeated course of advices that can be online. Some material the woman have to read it, and someone who will be like a counselor with her okay? And this course will continue for like 9 or 12 weeks of treatment, okay? This is what's called high intensity psychological intervention or pharmacological treatment or combination of both, okay? Tocophobia, as I talked about, it's one form of the anxiety disorders. Why it's very important? Because you will meet patient and in your real life and even in your exams, which have a fear for giving birth. Okay, how would that be managed? Management of that by referral to consultation. Okay, especially those women who are asking about cesarean section on maternal request. Okay, so if you remember in the NICE guideline of cesarean section, there was this part of cesarean section upon maternal request. So should be referred to a consultant-led unit. They will make a meeting with her, and after that, they should address what are the causes with non-judgmental way, and if there is any cause, they should address those causes and discuss with her how would you prevent this in the future, okay? And with some midwife who specialize in treating those cases, and the woman will be assigned to a certain midwife, okay? And she will follow her during pregnancy and give her a full support. If the woman insists on the cesarean section, so it's her decision, okay? Nobody can deny that. But a lot of women already say that the experience were better already after feeling supported from all the team, the consultant and the specialized midwife during pregnancy, okay? So, and they agree finally for vaginal birth. So this is how would you manage tocophobia, and tocophobia is a part of the anxiety disorder. Let's go to the other form of disorders, which is called the psychotic disorder. Psychotic disorders means associated with hallucination, maybe thoughts of self-harm or harm to the others, okay? So this is why it's very important. You have to pick up those patients with red flag signs, okay? So dealing with a psychotic patient, this patient with bipolar, schizophrenia, or schizoaffective disorder, or psychotic depression, okay, is very critical in, and you have to know how to pick them up and how to intervene very early, okay, because if they develop a form of psychosis, they can be very harmful to themselves or to the others around them. All women with history of psychotic disorder should be under care of psychiatric team, ideally a prenatal mental health team, okay? So those women from the start of pregnancy, they should be under psychiatric team follow-up, and ideally called prenatal mental health team. The woman should have some preconception counseling as well, because they use combination of drugs which are associated with side effect to the fetus. Okay, so very important to have a pre-counsel for those patients. And the birth planning meeting should be at 32 weeks of gestation. So you will arrange and coordinate with the health professional, including in her care, her plan of delivery, her postpartum period, and maybe prophylactic admission to what is called mother and baby unit. Okay, so you have to keep an eye on them during labor and after labor immediately. Okay, so you can act fast for those patients, especially those patients with history of psychosis. Bipolar disorder is a major risk factor for postpartum psychosis, and this is an exam question, single best answer question, asking about the bipolar disorder. The risk is 20 to 30% of patients with bipolar disorder will develop postpartum psychosis. Okay, so please keep all this percentage in your mind. I have highlighted this with red, so it will be easy for you to pick them up while you're studying. You have to maintain control of the bipolar symptoms during the prenatal period. and this is to prevent relapse in pregnancy and postpartum psychosis that can, in acute cases, can lead to suicide or fetal harm, baby harm. Treatment of bipolar disorder usually include combination of antipsychotic drugs, mood stabilizer, and benzodiazepines. Mood stabilizer, what is one of the most form of the mood stabilizer, or the famous one we have in our exams, is lithium. Okay, so we will talk later about the lithium and its effect, and about the antipsychotic drugs, because there is some antipsychotic drugs that increase the prolactin level. So maybe in a girl or a young lady that she's planning to get pregnant using antipsychotic drugs, you have to review their drugs and you have to do assessment of prolactin level, okay? Because if the prolactin level is high, so that can cause some form of subfertility, so you have to treat them or change the drug. Okay, this is mentioned also in the NICE guidelines. You have to know the safety of each drug in each condition. Schizophrenia is severe psychotic disorder that causes individuals to interpret reality abnormality. It's treated with combination of psychoeducation, psychological intervention, and antipsychotic medication. Women with schizophrenia should be under the care of prenatal team and may require prophylactic admission to the mother and baby unit after birth. Okay, one of the management that you have to know during your exams and your real life practice, when to say I will admit this patient to the mother and baby unit. Okay, if it is a form of acute admission or prophylactic admission. So which patient we use or we advise for a prophylactic admission to the mother and baby unit? Those patients with schizophrenia, or those patients with history of previous psychotic episodes. Okay, they will be in danger for themselves or for the others. I have now finished talking about psychiatric disorder or depression and anxiety and psychotic disorder in pregnancy. Now let's finish that and we moved to another stage. What is the other stage? The other stage is the postnatal period. Postnatal period, it has some specific disorders ranging from mild to very severe. Okay, we all know about postnatal blues, postnatal depression, and psychosis. Is it right? So what is the difference between postnatal blues, postnatal depression, and psychosis? Please, I know a lot of schools or a lot of tutors will tell you about how to differentiate between them by using the onset of the symptom appearance, which date, okay, the symptoms will appear. Means if the symptoms appeared in day 4, that will be postnatal blue, or it comes in like day 90, means that this is psychosis. Actually, please don't fall in this trap, okay, with respect to everybody, but this is the recommendation of the college itself. Okay, the college say, please don't depend on the onset of the symptoms only. Okay, so you have to know the symptoms, you have to know how to differentiate between them with symptoms. Let's say about postnatal blues. Postnatal blues, it's very common. 50 to 80 women, almost majority of pregnant women, when they give birth, after giving birth, especially the first baby, they will have disturbance of sleeping, they will have full of the level of hormones, they will have some maybe pain because of the delivery, okay, and discomfort. So they will start to suffer a little, suffer from some mood liability, low mood, maybe some tearing, okay, sometimes tearful episodes. Oh my God, I cannot feed the baby, okay, or he doesn't want to sleep, or I need to take a shower but I can't leave him alone, something like that. Okay, this is common, and this is a mild, and this is very acceptable. Okay, and it actually, baby blues can happen in primates and multi, okay, with no difference. And breastfeeding or both, bottle feeding also the same. Okay, so it's not increased like in women with breastfeeding, and it's a little bit in women with bottle feeding. Okay, no, it actually can happen for anyone regardless the type of the feeding. Okay, postnatal women will also associated with some form of irritability or some condition called hypochondriasis. Okay, what is this condition? This condition actually is about like the patient will be alerting, irritable, okay, and for every symptom that developed from her or the baby, she will call the doctor many times, a lot, in the first week or the second week of delivery, okay, asking about minor things. She maybe have like, if the baby vomits, she will cry, she will think the baby, oh, my baby have a lot of problem, maybe surgical, maybe he needs a CT scan, okay, or something like that. Okay, so this condition or irritability or anxiety after birth is acceptable. Okay, and it's usually self-limiting and only needs some support of the family and friends. And of course, there's a specific midwife that will take care of each woman after labor. Okay, they can help her in this period, okay, of irritability, and they give her some advices. Okay, so it's actually mild and self-limiting and no harm from it. Why you need to know it? You need to know it as a differential diagnosis. Okay, in your cases, you have to know when I choose postnatal blues, when I choose depression, and when I choose psychosis. It lasts around 48 hours and its peak around day 5 postpartum. Okay, only need some reassurance. Postnatal depression, okay, is different from blues. Postnatal depression defined as non-psychotic depressive illness occurring in the first postnatal year. So it's not only around the few days or few weeks postnatal, it's around the whole year after delivery, okay, which called postnatal depression. It's important to differentiate between the postnatal depression and blues, and to avoid those postnatal depression for as a generic term for all the psychiatric disorders, okay, because it makes a difference. If the woman has a history already of depression, she will be at more risk of developing postnatal depression. Okay, traumatic birth will be also at increased risk of postnatal depression. Okay, normal cases, the percentage is around 10 to 15% of all women complaining of this depression. It has two key peaks of diagnosis made between 2 to 4 weeks postpartum and 10 to 14 weeks postpartum. Okay, this is also a previous single best answer question asking about the peak of diagnosis of postnatal depression. The diagnosis of postnatal depression, if anyone who's very clever and remember what I said from the start, okay, about the holy question, when you ask a woman in the booking visit and also in the postnatal visit. First postnatal visit, you have to screen the woman for the depression. Okay, so when you ask her about how she's feeling low or anything, and you feel like she is depressive, then go for what is called Edinburgh Postnatal Depression Scale. Excellent, seems like everybody knows the answer. Okay, so Edinburgh postnatal depression scale is a 10-item self-rated questionnaire, means that the woman will fill it by herself and she will rate herself. It has been used extensively for detection of postpartum depression. What are the symptoms? Symptoms of postpartum depression: you have persistent sadness, low of interest or pleasure, fatigue, or low energy. Okay, but the difference of blues and depression, actually the blues is the form only of low mood, but depression called illness means that the woman is ill, like any woman, like the woman who's complaining of cardiac, hepatic, infectious disease, or any other major disorders. Okay, this woman with depression is also suffering, and she have a real illness. So you have to be supportive to your patient so you can understand that depression is an actual disease and she can talk about it non-judgmental way, not to be shamed, not to be like I'm a weak woman, I cannot take care of my family, I cannot take care of my baby. No, this is a period of major stress. There is a major change in your life. You have a baby, you have a new person in your life, you have pains as well, and you have responsibility, work, study, taking care of children, everything. Okay, so it's very normal to have a depression. Okay, and no shame of that, because a lot of women, they actually just forget about it, or they feel shamed, or they feel, oh my god, I will be like so soft if I said I'm depressed. Okay, and sorry to say that educated or non-educated, no difference. Okay, so just you have to know how to be soft, how to understand your patient complaint, how would you support her. Okay, of course, mild to moderate depression can be managed via like cognitive behavior therapy, or what is called low intensity intervention. Okay, it's just like supporting or someone to talk about it. Okay, or learning some strategies how to cope with this. Okay, but moderate depression or severe depression need definite treatment. What is the form of treatment? The form of treatment will be combination between behavior therapy or psychological intervention, okay, and drug therapy. What is the most common drug therapy used in depressive disorder? Anyone give me a name, please? I just want to make sure that you are still awake.
All right.
Okay, excellent, Dr. Suma. SSRIs, and what else? Yes, excellent. The SSRI are the most common drug that's used in the treatment of depression during antenatal or postnatal period, and we will discuss also some drug safety regarding the SSRI and different agents and how would you use them. Okay, but if we are talking about postnatal period, mainly sertraline will be the drug of choice. Why? Because it has report to be safe in the breastfeeding period. Cognitive behavior therapy as well can be used with a combination of the drug. Okay, so very important to know what is the drug of choice, and what is very important as well as the safety of your patient and safety of her family and the child, that when you detect a red flag sign, a red flag sign means a sign that will tell you, okay, this lady need an admission in the mother and baby unit, so a specialized team will take care of her and her baby. Okay, so the indication of admission in both in the mother and baby unit on a specialized perinatal mental health service are very important. Please don't leave this session today without knowing them. Okay, so we will assess the woman with severe depression for any sorts of self-harm or harm to the others. Okay, it's very important. What is the drug of choice in use of depression postnatal is the sertraline. Okay, and we will come back to the antenatal drug of the SSRIs when we talk about the drug therapy. It will be in a separate discussion. Okay, postpartum psychosis, this is the beast that we all fear of. Okay, this is the big problem that any woman can face. Okay, it can be very dangerous to the woman, can be very tragic in her life. For myself, I know, sorry, 2 cases at least in Dubai killing their babies. Okay, so it's very important for a good doctor or a good team to pick up the patient who has an early signs of psychosis. Very important for the safety of the patient and safety of her baby. Postpartum psychosis, the first sign of illness can often be non-specific, but symptoms such as insomnia, okay, especially severe insomnia, or when he tell you in the case that the lady didn't sleep for 3 days, okay, like that. So this is the mean of severe insomnia. Agitation or any odd behavior, okay, can raise the suspicion of psychosis. Progression is often rapid, and few hours later the woman is considered psychotic and often severely disturbed. What are the manifestations of a psychotic patient? Hallucination, delusions, fear, confusion, agitation. Sometimes should be very aggressive to the others. Women with puerperal psychosis are more commonly to have manic symptoms such as mood liability, pressured speech, or distractibility. Women with psychotic disorder outside this period, okay, will have less symptoms, but postnatal psychosis is a severe form of psychosis. Women with puerperal psychosis often present with rapidly changing mental state. Okay, that's why postpartum psychosis is an emergency. Okay, it's a psychiatric emergency, an obstetric emergency, and the woman should have been seen and started treatment within how many hours? Guys, very important. How many hours you should start? The woman should have been seen, referred, and started treatment. You know, when we talk about the sepsis that we should address this in 1 hour. Okay, so postpartum psychosis should be done in 4 hours. Okay, 4 hours. Please remember, it's a 4-hour window only from the moment you see your patient, you suspect the hair with odd behavior. Sometimes it will be non-specific symptoms. It will be like only she's disturbed, or she doesn't know where she is, or she's talking like strange talk. Okay, 4 hours should be assessed by psychiatrist and started treatment. Okay, so it's very important to know your window of management, because it can progress very fast into acute psychosis, and the woman will be harmful to herself, to her baby, even to her family. And there is big tragedy in the UK few years ago, and maybe some of you heard about it, when a doctor, okay, she was giving birth to a baby, she had another baby at home, and it ended up by she killed herself and the 2 boys. Okay, so it's very important when you recognize this, early recognition and early intervention, okay, for the postpartum psychosis. Onset is early in the postnatal period, okay, 50% of cases will present by day 7, okay, 75% will present by day 16, okay, and it can be up to day 90, okay. So 3 months after delivery, still the woman can present with psychosis. 95% of the cases present by day 90, means that you still have 5% as well can present later on those 3 months. It's important to note that the woman can break down and relapse early in labor, and sometimes the early signs or the early symptoms of psychosis start with the onset of labor. Okay, so the woman will start the odd behavior or the change in her mental state during labor, and sometimes it would be very early in labor. Okay, so you have to know this. Also, this one is a recall question, asking about the symptoms start from the onset of labor and can be with the early sign of labor as well. Okay, so very early in labor, the woman can develop symptoms of psychosis. Let's come to the diagnosis and management. Postpartum psychosis, as I said, it's psychiatric emergency, and women require assessment by trained psychiatrists. In particular, they should pay attention to suicidal or infanticidal ideas. The well-being of a baby, as well as her partner and other children, must be considered as well. Up to 78% of women with puerperal psychosis have delusional idea about their infant. Okay, and this is the problem comes from here. They have some delusional idea about the babies, so this is why they're very dangerous to their babies. Okay, because sometimes they feel that this is an alien. Okay, and this is reported as well by some patients that she feels that he is an alien. This is not my baby is still inside. Okay, and myself, I have experience with one patient that after delivery, she was insisting that there is another baby inside, and she wants to take a knife and open her abdomen to take the baby out. Okay, so very tragic actually situation. While awaiting of psychiatric assessment, women should not be left alone and ideally should be supervised by one-to-one registered mental health nurse. Okay, so one-to-one supervision. Okay, the nurse will not leave her even day or night. Prompt recognition and management may help prevent the most severe consequences for the woman and her family. Women with acute psychotic symptoms require inpatient management and should ideally be admitted to the mother and baby unit to allow bonding to continue with their newborn child, because it is not a good idea to take the baby all the way from her. Okay, after the acute management or the acute phase passed, after that they will work on making a bond or relation between the mother and baby. Most will require treatment with antipsychotic medication depending on their symptoms. They may also require antidepressant or mood stabilizer. Ideally, medication is safe to use if breastfeeding should be prescribed. Puerperal psychosis, well, it's very, very responsive to ECT, okay? And of course, the ECT is done under general anesthesia, okay? It's a very safe treatment and it's effective in treatment of psychosis. What is the prognosis of a psychosis? Once the acute phase is settled, the patient will often benefit from psychotherapy and education about their condition, the risk of recurrence, and the strategies for prevention following future pregnancy. Contraceptive advice should also be given. With the corrected treatment, the short-term prognosis is generally good. Risk of recurrence in future pregnancy is high. Okay, so women with one episode of psychosis she will develop 1 in 2 chances, or 50% chances that she will develop another episode after next pregnancy. Okay, small cohort study have shown that prophylaxis with lithium or olanzapine may help reduce recurrence, but at present there is insufficient good quality evidence to advise prophylaxis in all women with history of this condition. And of course, here comes the rule of elective admission to a mother and baby unit required following future deliveries. Okay, because you will not wait in such a high-risk woman who had a history of psychosis to have another episode while she's alone at home. Okay, so you consider prophylactic admission in the mother and baby unit, where she will be supervised by one-to-one nurse who is trained in management of mental disorder. Prognosis after this episode passed, okay, not only for the future pregnancy, but sometimes in their current life, in their future life, they will develop bipolar disorders, okay? Up to 1/3 or 2/3 of patients with psychosis will suffer an episode of postpartum psychosis, and they will develop bipolar disorder. In this case, the mood stabilizers are recommended for the long-term treatment of bipolar disorder. Okay, so here comes the role of mood stabilizers. What are the red flag signs in prenatal mental health? Okay, which you have to pick in the case, and you have to treat or to refer according to it. Okay, a good doctor or a good candidate who know the non-specific symptoms before the acute symptoms. Okay, so let's see what are those red flag signs. Red flag signs or warning of impending danger or disaster in the context of severe perinatal mental health. This means either the mother, her infant, or both, or other members of her family are at high risk because of severe mental illness. Those red flags include recent or rapidly changing significant alteration in mental state, emergence of new symptoms, which can include psychotic symptoms like delusions, hallucination, or severe anxiety in relation to her infant or to other children as well. Psychotic symptoms that involve the infant, this is very important to rule this out, and it's a key in the diagnosis. Thoughts of violent self-harm or suicide or acts, okay? So the woman may have only a thought or already started act to self-harm or others harm. New persistent, non-reasonable idea and the expression of this idea where the woman believes she is incompetent or inadequate as a mother or feels estranged from her infant. Actually, this is the trick here, okay? This is where I can say by myself, a good candidate should not, okay, leave these words to pass without making stress of it, especially in part 3 when this is the key of diagnosis. When you talk to the woman and she gives you a history, I'm feeling like an incompetent mother or an inadequate mother, okay? This is a key word or a red flag signs of developing psychosis. Okay, it is not maybe an early signs, but it is not to be passed. Okay, it is not postnatal blues or mild illness. This is a sign of developing, this woman is developing a severe illness. Feeling of guilt or feeling like she's hopelessness, okay, especially those patients who will tell you, okay, if the baby is admitted to the neonatal ICU, okay, they may feel this is my mistake, I have done that to myself, I have done that to my son, and the baby will be okay or not, and if the baby developed any complication or didn't survive. Okay, sometimes a woman, okay, will have this feeling of guilt or hopelessness, and this guilt feeling can be very dangerous to her, and this can lead to some suicidal thoughts as well. Okay, especially those women with difficult delivery or baby being admitted after operative vaginal delivery or prolonged labor. Okay, she may blame herself that she didn't push enough or she didn't help her baby enough. Okay, so this is a very common actually complication happens to a difficult or a traumatic birth. Deterioration in function as a sequence of symptoms like she cannot take care of herself, she cannot take care of her infant, or she avoids the infant. Okay, those also dangerous signs or red flag signs that can be counted by some candidates as a common presentation after delivery or counted as a baby flu. Okay, if the woman is non-functional, means that she cannot take care of herself, cannot take care of her baby, or she want to avoid the baby. This all one symptoms of the red flag signs. She's not eating, she refused to eat after delivery. Severe insomnia, as I said, it can take days, or psychomotor retardation. What are the indication to referral for prenatal mental health service? Prenatal mental health service doesn't mean admission, okay? Doesn't mean that a woman will definitely need admission. Let's see which woman you will refer for those specialized service or what's called prenatal mental health service. Woman with current illness where there are symptoms of psychosis, severe anxiety, severe depression, or self-neglected or harm to the other or significant interference with daily function. Such illness may include psychotic disorder, severe anxiety or depression, or OCDs or eating disorders. Woman with history of bipolar or schizophrenia, woman with previous serious postpartum mental illness, means Postpartum Psychosis, woman on complex psychotropic medication regimen. Referral should be considered for whom? Referral should be considered for women with illness of moderate severely at developing in late pregnancy or in early postpartum period. Women with current illness of mid or moderate severity where there is a first degree relative with bipolar disorder or peripheral psychosis. In the absence of current illness such as family history indicates raised but low absolute risk of early postpartum serious mental health. Where indicated, information should be shared with primary care, and any evidence of mood disturbance during pregnancy or in the postpartum period should lead to referral. Women with previous period of inpatient mental health care should be screened by mental health service, either by assessing case record or seeing the woman herself. Okay, even if the woman comes early in the booking state or comes early in pregnancy, but she has history, she should be assessed. Her record should be assessed, or even to make an interview with her. Maternity service need to ensure that appropriate communication with primary care and social service where necessary. All this will take place for the woman who declined referral to specialized mental health service. Okay, so I'll stop here before starting the drugs and ask you if you can understand what are the red flag signs and what are the indication of referral to the specialized service of prenatal mental health. So starting questions, you can write down in the chat box or open your mic as you feel.
Hello.
Hello, Dr. Fonny. How are you? Yes, dear, I'm here.
I'm, yes, I think the red flag signs are those signs that means that the woman could be dangerous to herself or her baby or other children or the family member. So those signs that you pick from the symptoms that the woman presented with. So for symptoms of psychosis like hallucination, delusion, okay, confusion, agitation, severe anxiety, so that could lead to puerperal psychosis, it could be. Or when a woman feels incompetent, inadequate to care for her baby, and those symptoms has consequence over her that make her to be not to care for herself or care for the infant or avoid the infant. And maybe she's not eating well, not sleeping, severe insomnia, feeling guilt and hopelessness. So those are the red flag signs that you can pick. And if you can see that she had thoughts of suicidal attempts, then those are the red flag signs that you should pick.
Yes, thank you very much. And you are, Dr. Fonmi, one example of a competent candidate. Thank you.
You said what?
This is an example, as I said, you, Dr. Fonmi, you represent a competent candidate. Okay, I know there is a disturbance in the voice, or some echo in the voice. Okay. So thank you very much, Dr. Fonmi. I appreciate your sharing with us today. Thank you very much. So any other symptoms before going to the treatment? Any other questions? Right. Okay, so shall we move to the treatment, and which is a very common part in your exams and part of the update of the guideline, okay, and where you will be asked a lot regarding the side effect and manifestation of the drug and effect of the baby and neonate. Very important drug treatment and safety consideration. Okay, we'll start by the commonest one used in antenatal and postnatal period, which is the SSRI or the SNRI. Okay, famous agent like sertraline, paroxetine, fluoxetine, okay, are there, and every one of them of us are familiar with those drugs. But what are the risks of those drugs? They are not without risk. Actually, there is a risk. It's a possible or a small risk, but you should have known it, and you also should know that it comes in the exam. And specifically, they asked not for the SSRI, they have asked about the paroxetine, okay, as a specific problem associated with paroxetine over sertraline. Okay, so let's have a look to the risk. Okay, we have possible increase in rate of congenital malformation and small increase in risk of resistant pulmonary hypertension of the newborn. Poor neonatal adaptation syndrome. Paroxetine has been linked to fetal cardiac abnormality. Okay, and this is the recall question. The best evidence for the SSRI and SNRI and breastfeeding suggests that sertraline and paroxetine can be used not antenatal but can be used in the postnatal in the breastfeeding. Okay, and they have shown, it has been shown, no reports of short-term adverse outcome. Okay, yet the recommended treatment in breastfeeding is sertraline. Paroxetine should not be used due to the fear of fetal cardiac abnormalities. Tricyclic antidepressant, including the amitriptyline or imipramine, famous agent, effective in treatment of depressive disorder and also in the treatment of anxiety disorder as well. Okay, it's not not associated with miscarriage or congenital malformation. But there is some complication related to the overdose of use of tricyclic antidepressants. The level of tricyclic antidepressant in breast milk appear to be low. The exception is the doxepin, which should be avoided in lactation. Okay, so the most unsafe drug from the tricyclic antidepressant drug is the doxepin. Tricyclic antidepressants are not used as commonly in depression as SSRI due to the risk of overdose. Okay, this is what you need to know about treatment of depression or the anxiety. Here comes the lithium. Okay, lithium, which is very important, very common in your exams, so many questions and repeated recalls about lithium. So let's know some information about lithium. We use lithium a treatment of mood stabilizer. It's very effective as a mood stabilizer and with a very good result to the patient, but it's risky to the baby. Okay, so what are the risks or the side effect of the lithium? It's Epstein anomaly, cardiac anomaly in the neonate, or neonatal adaptation syndrome. What is the Epstein anomaly? It's a congenital heart defect in which the septal and posterior leaflet of tricuspid valve are displaced towards the apex of the right ventricle of the heart. Okay, this is the definition of the Epstein anomaly. I will be very grateful if you only know the names, okay, and you know that this is septal defect. Okay, updated NICE guideline recommend that lithium should not be offered to women who are pregnant or planning for pregnancy unless all other antipsychotic has been failed. So it's the same safety advice for the sodium valproate, but add to that the sodium valproate should not be written to any girl or any woman in a childbearing period unless with effective contraception in place and all other choices has been failed. There is increased risk of relapse if the drug is stopped abruptly. So if a woman is planning to get pregnant or she knows that she is pregnant with lithium use, what should she do? Okay, you have to take counselor from her specialist, her perinatal mental health specialist, or her psychiatric perinatal psychiatrist. They will take the drug gradually, okay, and replace it with another safe alternative. Let's assume that this is the only drug to control this woman's symptoms. Okay, if this is the only drug to control her symptoms, so woman should be counseled about the risk and the effect on the baby, and there should be antenatal monitoring of lithium. Okay, so if there is antenatal monitoring of lithium, you will be asked about it. Okay, because the safety, it has a very narrow safety for the lithium. Actually, the levels of toxicity start from. Can anybody suggest this is the level of lithium? Any answer?
The level should be, ma'am, should be less than 1.2 millimole per liter.
Okay, excellent. Thank you very much, doctor. So yes, the level should be less than 1.2 millimole per liter. This is the lithium level, okay? What are the manifestations of lithium toxicity? Start from nausea, vomiting, cramps, sometimes diarrhea. What is the severe form of lithium toxicity? there will be neuromuscular signs such as tremors, dystonia, hyperreflexia, ataxia, cardiac dysrhythmia can happen, although it's rare. Okay, so the manifestation or the lithium has an effect on the baby and on the mother. Okay, effects on of the lithium toxicity on mother should be known by heart. Let's say it again: nausea, vomiting, cramping, diarrhea, sometimes severe form of neuromuscular signs, tremors, hyperreflexia, ataxia, sometimes cardiac dysrhythmia can happen, and the ECG finding, which is specific to the lithium toxicity, is T-wave flattening. Okay, so when you have in the exam, flattening of the T-wave in the ECG means this is associated with lithium toxicity. Okay, level of lithium should be checked every 4 weeks till 36 weeks of pregnancy, and after that should be checked every week. Okay, it can have also some manifestation. You should ensure that the woman have taken good fluid orally to avoid any ureteric stone, any obstruction, okay, because this will lead to lithium accumulation and toxicity. And of course, delivery of a patient with psychotic disorder or any patient with lithium or mood stabilizer should be in hospital with what? With a prophylactic admission to?
MBU.
Yes, Dr. Asimo, thank you very much. With the prophylactic admission to the mother and baby unit. Okay, so moving to the next manifestation of lithium. Lithium should be withheld during labor and childbirth, okay, because there is a higher placental transfer rate happens during labor. So it should be stopped during labor, and this will lead to some specific adverse, and which is associated with low Apgar score, neuromuscular complication in the infant, okay, due to the higher dose of lithium exposure at delivery. Lithium level should be checked 12 hours after birth, okay, so you can determine if you will give the next dose or not. Lithium is not advised in breastfeeding, okay, so if the woman cannot stop lithium, you should advise her. What will be the advice? You should advise her not to breastfeed.
Breastfeed.
Okay, thank you very much. Here is the sodium valproate. I'm sorry for running fast, but if you have any question, please stop me at any point. The sodium valproate, what is the new advice or the MHRA advice? That it should not be offered for acute or long-term treatment of a mental health problem in women or girls who are planning for a pregnant or considering breastfeeding. Valproate must not be used in girls and women unless alternative treatments are not suitable and the pregnancy prevention program is in place. There is a MHRA safety advice on valproate use by women and girls. This you can go Google it, okay, and you can read it in details. It's very nice actually. And there is a patient booklet written in a simple language for the patient so they can know by themselves what are the manifestation and side effects of using lithium valproate during the childbearing period. What are the manifestations of the sodium valproate? There is increased risk of teratogenicity and adverse developmental effects and not consistent across the different mood stabilizers. Okay, so let's see what are the specific fetal malformation associated with sodium valproate. It's first neural tube defect, cardiac abnormality, skeletal abnormality, hypospadias, fetal valproate syndrome. And there is neurodevelopmental effect, means the baby will complain of low IQ, poor motor function, poor language skill, impaired emotional function, impaired behavior function, and increased risk of autism and autistic spectrum disorder. Okay, so the neurodevelopmental effect of the sodium valproate on the baby are very, very serious. Okay. Hopefully the screen is clear. Okay, so please let's revise again. Fetal malformation and what is the neurodevelopmental effect of the valproate, so you know how much this drug is problematic to the baby, and you know the aim of the safety alert. Okay, again, it's a neural tubal defect, cardiac abnormality, skeletal abnormality, hypospadiasm, and fetal valproate syndrome, lower IQ, poor motor function, poor language skill, impaired emotional function, and impaired behavior function, increased risk of autism and autistic spectrum disorder. Comes to carbamazepine. Any question about sodium valproate? Any question regarding lithium? So if you didn't ask me, I will ask you. Okay? So no questions at all? No question means either it's a very boring topic or very poor instructor or excellent instructor. So which one of them? I don't think the third one is.
This conference will now be recorded.
Carbamazepine have already a safety notice from the NICE guideline. The NICE say don't offer the carbamazepine to treat a mental health problem in women who are planning for pregnancy, women who are pregnant, or considering breastfeeding. Okay, so carbamazepine is contraindicated in the three of them. Okay, planning for pregnancy, pregnant, or breastfeeding. If a woman is already taking carbamazepine and is planning for a pregnancy or become pregnant, discuss with the woman the possibility of stopping the drug because the risk of adverse drug interaction and fetal malformation. And stopping the drug will not be by yourself, but with the prenatal mental health service, okay, and the specialized doctor. The antipsychotics known to be with a side effect on the ladies, raising of prolactin levels. Okay, so the safety also advice from the NICE guidelines regarding antipsychotic drugs is there is limited data of safety on the safety of those drugs in pregnancy and breastfeeding. And if the woman comes in the preconception and she is planning to be pregnant with those antipsychotic medication, measure the prolactin levels. Okay, so measuring prolactin level for those women, because some of those drugs known to raise the prolactin level, and if the prolactin level is high, so this will cause some form of subfertility. So it should be referred to the psychiatrist to change this drug to another prolactin sparing antipsychotic. Don't offer debut antipsychotic to a woman who's planning to be pregnant or considering breastfeeding, unless she is responding well to debut and has previous history of non-adherence to the oral medications. Okay, so even the form of the drug, if the drug is already allowed in pregnancy or breastfeeding, okay, don't give the debut for okay, start with the oral form. If the woman is non-adherent to the oral medication, then in this case only she can take the debut form of the drug. Here is some general principles of the treatment of psychotic disorder or depression during pregnancy. So I would like to review them with you. Depression that is left untreated in pregnancy, either because symptoms are not recognized or because concern regarding effect of medication, can lead to adverse consequences. What are the consequences of depression in pregnancy? Okay. First, it will be lack of compliance with the recommendation. Second, poor nutrition and self-care. Third, self-medications, okay, and they can harm themselves. They can go for alcohol or drug use. They can have suicidal thoughts or thoughts of harming the fetus. Resistant depression into the postnatal period can cause, if depression is left untreated during the postnatal, can affect the fetus, and some studies have demonstrated an associated between spontaneous abortion, lower gestational age, lower infant birth weight, and lower MRCOG score, preeclampsia, neonatal intensive care unit admission, and breastfeeding initiation. Depression can also impact on the woman's partner, other children, and wider social network. Early detection treatment is essential. Okay, those studies that link depression in pregnancy with the abortion or low birth weight or NICU admission or low MRCOG score, not only everything. Okay, so the fetus can be at harm from the disease itself, from the depression itself. But also they found by the follow-up, and those fetuses will become babies, after that will become children, okay, they have manifestation in the long run because the mother has a depression which is not treated during pregnancy. Okay, it's something like they will inherit the depression from her. Okay, so those children found to be have social problem after delivery, okay, and in early childhood, and they may be also liable to childhood depression. Okay, so the manifestation of depression not only for the woman and also for the baby and his future. Okay, so that's why it's very important and very essential that the woman can have her treatment during pregnancy, and the pregnancy is not a cause to stop the treatment. Okay, and because the pregnancy manifestation itself somehow, okay, looks like depression, and some people will say this is hormonal changes or some low mood which is common with pregnancy. Okay, you as a competent doctor and a member of the RCOG have to take care of that. You have to take care of which patient should have been treated, and you will do that by this question for the smart people who attended the session from the start, and they will tell me.
Questionnaire first.
Get to questionnaire.
Okay, thank you very much. So Dr. Mustafa say get to is for generalized anxiety disorder scale. Okay, so we screen for depression by, yes, they are related
Woolly
to anxiety
questions.
and depression. Yes, by the
Woolly
Woolly questions. Yes, thank you very much, Dr. Asima. So, and if the woman answered positive to the Woolly questions, what is next questionnaire you will offer her?
Depression. The health questionnaire. Depression health questionnaire. Patient health questionnaire.
Okay, so it's if the woman in the antenatal period, it will be the patient health questionnaire, okay, or the BHQ-9 questionnaire, okay, which is self-rated questionnaire. The woman will fill it by herself and she will give herself the rate, okay. If the woman in the postnatal period means now you meet the woman in the postnatal ward or in the postnatal visit, you start with the holy question, and if the woman answer
Edinburgh.
positive, yes, thank you very much, the Edinburgh, okay, postnatal health questionnaire. So names of questionnaire, very important as well. And when you do your screening tools correctly, you can pick up which woman who needs intervention and which woman you needs your treatment, okay? So mild to moderate depression, what is the recommendation of treatment? Women presenting with mild depression will be referred to local psychology service known as IAPT, which stands for Improving Access to Psychological Therapy Service, or Primary Care Mental Health Service. I think this is the easy name, Primary Care Mental Health Service. Because it's the primary care means that we refer mild to moderate women first to the primary care, okay? Try to remind yourself like that, where they will be offered low intensity psychological input. What is the low intensity psychological input? This includes reading and accessing online material based on a cognitive behavior model. The course lasts for 9 to 12 weeks with 6 to 8 sessions or face-to-face or telephone contact with a facilitator. Okay, so this is kind of cognitive behavior therapy that is evidence-based to help the woman, and actually it can work, okay, in alleviating their symptoms. This is what's called low intensity psychological input. So if you have it between the choices, you know what it is. While moderate to severe depression, the treatment choice will depend on the individual presentation, history, and response to previous treatment and preferences. What are the options? Either pharmacological treatment alone or pharmacological treatment with high intensity psychological intervention. Okay, so remember, for the moderate to severe depression, you can do combination of both treatments. The treatment will be high intensity psychological intervention, which will focus more on the cognitive behavior therapy for the woman, and this is an evidence-based with the facilitator. Pharmacological treatment in the form of selective serotonin reuptake inhibitor, or SNRI, the selective serotonin and norepinephrine reuptake inhibitor, or the tricyclic antidepressant. And I would like to remind you the safety of each one of them. The paroxetine, one of the SSRI, is linked to the recall
Cardiac
question.
abnormality.
Yes, thank you very much. Okay, so paroxetine is not preferred to use during pregnancy. Other SSRIs may be much safer in this context. But SSRIs is not without side effects. There is a low risk of, can anybody of you remind me with the safety issue regarding SSRI? Low risk of? There's two conditions
Congenital
related.
malformations.
Okay, please be more specific.
Neurodevelopmental issues, I think.
Okay, neurodevelopmental issues is related to valproate. Okay, so
Ma'am,
Dr. Mustafa.
for
Yes.
neonatal adaptation syndrome, ma'am.
Okay, thank you very much. Poor neonatal adaptation syndrome is one of the side effects, And the other famous side effect of the SSRI is resistant pulmonary hypertension, okay, of the newborn. Resistant pulmonary hypertension of the newborn. This is the famous problem that happen or related to the SSRI. It's a low risk or small risk, but it's there, so you should know it. Again, excuse me, I said this session will not finish unless we all know everything about them. Okay, small increased risk of resistant pulmonary hypertension of the newborn. Born neonatal adaptation syndrome. Paroxetine is related to fetal cardiac abnormality. Okay, so please, those questions were repeated recall, so please don't lose this one. Okay, you will be sitting in the exam and confused between the choices. Okay, so from now I'm just guiding you. Please take care of the side effects. Which agent of the SSRI recommended to use or the drug of use in the breastfeeding woman?
Sertraline.
Sertraline.
Okay,
Sertraline.
excellent. It's sertraline. Okay, so we now all know how would you start the treatment of a woman with moderate to severe depression. You will give her either SSRI or SNRI or tricyclic antidepressant, okay, which is, by the way, not related to miscarriage or fetal malformation, but the safety concern about the tricyclic antidepressant is the drug overdose. Okay?
Doxepin.
Yes. And what is the second form of treatment? The CBD or cognitive behavior therapy, or what is called high intensity psychological intervention. So treatment of moderate to severe depression, please again. It's a form of behavior therapy, high intensity psychological intervention, or drug treatment, either SSRI, SNRI, or tricyclic antidepressant, or combination of both, especially if severe depression, okay, or depression with catatonic feature or psychotic features. What you will do?
ECT.
ECT is good choice, but it's the last choice. Okay? Treatment option for more severe episodes include switching antidepressant, augmenting treatment with an antipsychotic or mood stabilizer. So you can add antipsychotic or mood stabilizer to the antidepressant drug. And in very severe or life-threatening cases, the ECT. So we use the electroconvulsive therapy only in severe or life-threatening cases, okay? And of course, done under general anesthesia. So guys, is it clear?
Dr. Abba, this ECT is always done under GA?
I will tell you something, okay? If a woman pregnant and you want to treat her with an electric current, so what form of analgesia or anesthesia you will give her?
Maybe GA only.
So let's revise some key points. And after those key points, we will just solve some questions, few number of questions, and our session of today will end. Puerperal psychosis is more common in women with a family history of the condition and those with bipolar disorder. Can you please remind me with the risk in a woman with family history and woman with bipolar? The risk is different between both of them.
Bipolar 20 to 30%,
Yes, excellent.
and 50 with family history.
Yes, excellent, doctor. Thank you very much.
Yes, thank you. You're very
So
welcome.
the risk is, thank you. So the risk is higher with those women with the family history, especially in first degree relative. That's why very important when you ask about obstetric history to ask about family history of mental health. Okay, it's often present with non-specific symptoms and progressive rapidly to psychosis with hallucinations, delusions, fear, irritability, confusion, and agitation. And remember, please, the 4-hour window for treatment. Okay, this is an immediate emergency, psychiatric emergency, and women need to be seen by perinatal psychiatrists and assist in start the treatment within the 4 hours. The onset is often in the first week postpartum. Prompt referral to the emergency psychiatry team is required and ideally admission to the mother and baby young. Treatment is likely to include antipsychotic medication. Around 50% will develop the condition in a future pregnancy, and up to 65% will develop bipolar disorder. So there is a relation. Bipolar disorder increase the risk of postpartum psychosis, and postpartum psychosis, if the woman has no history of bipolar, will increase the risk, but it will increase the risk 65%. Okay, so there's much relation between bipolar disorder and psychotic disorder, postnatal psychosis. The highest risk time for suicide is late pregnancy and in the first 12 weeks postpartum. Single breast cancer question. It's more common in women with history of serious mental illness. Of course, methods of suicide in this period are more likely to be violent than outside this period. Okay, so they would think about harming themselves badly. Okay, so they may be very violent to themselves or the infants. I hope this topic is clear, guys. And if any questions before ask you some questions.
Doctor, we couldn't view the key points slide early on. The screen is not moving.
Okay, guys. Okay, I'll start just moving to the questions. Okay, last slide. I will repeat it again. I will bring it again before the question. Okay, you're welcome. So let's see the questions. Moving to the question 1 second. We stopped at question 7. Very few questions actually remaining. Single woman has schizophrenia experienced her first schizophrenic episode requiring inpatient psychiatric care. 8 months prior to pregnancy, she has been well controlled on haloperidol depot injection since she is currently at 36 weeks of gestation and as well, she lives alone and has limited social support. Okay, so the woman is taking antipsychotic drugs. She is schizophrenic. She's high risk of developing psychosis postnatal, and she's living alone. So what is the most appropriate place for her care in the postnatal period?
NBU as a prophylaxis, I think, Dr. Rabba.
Yes, okay. So choice is,
B.
yes, Dr. Mustafa, excellent. Yes, thank you very
B.
much. It's B. Yes, thank you very much. The choice is B, of course, specialist mother and baby unit, where the interaction between the mother and baby can be observed. Thank you very much. So next question. Woman comes to the antenatal clinic at 16-week gestation. She tells you that following her previous pregnancy, she was admitted to the mother-baby unit for a few weeks. She is unable to tell you what her diagnosis was. Okay, so she was admitted for a few weeks, means something serious. Okay, but she doesn't know the cause. Okay, and she's adamant that she doesn't want to go back there again. Okay, and she now doesn't want to go back there. She declines an outpatient appointment with the prenatal team. Okay, so even the woman doesn't want to be seen by the prenatal mental health team. She says that she currently has no psychiatric symptoms and is not on any medication. What is the best management plan in this situation? What she will do? Admit her to the mother and baby unit immediately, arrange urgent referral to the prenatal psychiatric team, or find out what happened after her last pregnancy and arrange a follow-up to discuss your findings, or discharge her for GB and follow-up, or discharge her back to midwife-led care unit. As she said that now she's not on any medication, what she will do?
We have
C.
to find out what happened, ma'am. See, ma'am.
Yes, excellent. Yes, excellent, excellent. Yes, you should find out what happened to her. Okay. Of course, you will not arrange an urgent referral again to the prenatal psychiatric team because she's not an urgent case. This is the first thing. Second thing, that she refused the previous appointment. So how would you just refer her again? She will not go to the appointment simply. Okay, so you will try to contact with her team, her previous team, you take her records from her GB, okay, and you will try to find what happened to her and follow up appointment, so you will discuss your plan from there. Okay, next question. 30-year-old woman develops postnatal depression. She is treated with antidepressant by her GB and gradually makes a full recovery. She stopped her antidepressant for a few months before she is conceiving again. What is the most likely outcome following this pregnancy? Okay, the woman has postnatal depression, okay, and she had history of using antidepressant and she made full recovery, and she stopped her antidepressant for a few months before she's conceiving again. What do you think?
B.
B. She's at risk of developing postpartum depression again. So she has to take the drug again.
Okay. Yes, so everybody agree with B, and excellent. B is the answer. She is at 1 to 2 or 1 to 3 risk of developing postpartum depression again. Thank you very much. Number 10, woman present 5 days post-delivery on labor ward. On an initial assessment, she is tearful and visible distress. But moments later, she starts laughing and then become highly irritable. So this is normal, or this is an odd behavior? She is reported to have disclosed to staff that she believes her 5-day-old son is able to communicate with God. So now she has some delusions and hallucinations.
C.
What is the most appropriate? Okay, so you will contact the local perinatal psychiatry team or psychiatric liaison team to request an urgent assessment with a view to the NPU admission. Okay, so everybody agree with Dr. Mustafa? Or you need to read the
Yes.
question again?
Yes, ma'am.
Okay, so I will move to the last question. Woman with postnatal blues. What do you think? Is most likely to be primary gravid woman than a parent woman? Or can present with confusion? Or can present with hypochondriasis? Or is most likely to be breastfeeding? Or is most likely between day 2 and day 3 postpartum?
Present with hypochondriasis. C. The answer.
Okay, thank you very much. Thank you.
The screen
Excellent.
has not changed, Dr. Abba.
Really? Why is
Last
not
question. Yeah, thank you.
Oh, sorry. Okay, I have to refresh it again. Can you please refresh it from your side as well? Okay, so woman with
Yeah,
postnatal
thanks.
blues, this is the question again. You're welcome. What is the most likely manifestation? The most likely manifestation that she will have hypochondriasis, which is always worried and stressed, such as this girl, okay? And she will be visiting or calling her doctors a lot, okay? So thank you very much for having me today, and I'm so sorry if I've been boring to any one of you.
You never do
Thank you
that.
so much.
Thank you so much, ma'am. It was
Dr.
really
Abba, thank you
useful,
so much.
ma'am. It was really a feast, ma'am.
Okay, thank you
Really,
very
your
much.
Dr. Abba, I'm
efforts are
sorry.
appreciated.
Dr. Abba,
Okay.
I have a
Yes.
question related monochorionic twins. Can I ask it now or later in the revision?
Okay, so can I stop the recording now?
Sure.